Hello everyone, you are all welcome. This is another video lesson from the introductory module, Unit 1, on narrative medicine. This time we are going to explore the debate about the current place of narrative in the hierarchy of evidence. As the name suggests, evidence-based medicine, EVM, is about finding evidence and using that evidence to make clinical decisions. A cornerstone of EVM is the hierarchical system of classifying evidence. This hierarchy is known as the levels of evidence. Health professionals are encouraged to find the highest levels of evidence to answer clinical questions. Discussions on how to define the different levels of evidence from a variety of research papers have been discussed over the last decades, as well as how to include these reflections in clinical practice. The levels of evidence were originally described in a report by the Canadian Task Force on the Periodic Health Examinations in 1979. The experts' opinions appear at the lowest levels, and remembers opinions, not experience, and always, of course, from experts. The levels of evidence were further described and expanded by Sackett in an article on levels of evidence for antithrombotic agents in 1989. This is the paper. And this is the new rank of evidence, level 1, 2, 3, 4, and 5. Both systems place randomized control trials, RCT, at the highest levels and case series or experts' opinions at the lowest level. The hierarchy ranks studies according to the probability of bias. RTC are given the highest level because they are designed to be unbiased and have less risk of systematic error. Since the introduction of levels of evidence, several other organizations have adopted variations of the classification systems. Diverse specialties are often asking different questions, and it's worth recognizing that the type and the level of evidence needed to be modified accordingly. Research questions are divided into the following categories: treatment, prognosis, diagnosis, and economic decision analysis. For example, this table shows the levels developed by the Center Evidence-Based Medicine for treatment. Also, a grading system that provides strength of recommendations based on evidence has also changed over time. In addition, we must remember that we need to review the quality of the work submitted, not just the type of study. The first and the earliest principle of evidence-based medicine indicate that a hierarchy of evidence exists. Not all evidence is the same. This principle became well known in the early 19th as practicing physicians learned basic clinical epidemiology skills and started to appraise and apply evidence to their practice. Since evidence was described as a hierarchy, a compelling rationale for a pyramid was made. Evidence-based healthcare practitioners became familiar with this pyramid when reading the literature, applying evidence, or teaching studies. You can take a look at this paper, it's open, and you can take a look also with the current debate about this topic. Sorry. Another version, the sixth pyramid, was also developed to describe the sources of evidence that can be used by evidence-based medicine practitioners for answering foreground questions, showing a hierarchy ranging from studies, synopsis, synthesis, synopsis of synthesis, summaries, and synthesis. It's important to note that this hierarchy may imply some sort of increasing validity and applicability, although its main purpose is to emphasize that the lower sources of evidence in the hierarchy are least preferred in practice because they require more expertise and time to identify, appraise, and apply, but remember, can be used. Criticism of simplistic view of the pyramid or problems with placing systematic reviews at the top have led to a new proposal. As you can see in this slide, lines separating the study design become wavy, grading of recommendation statement, development, and evaluation, and the systematic reviews are chopped off the pyramid. This is the new model. Study designs alone appear to be insufficient on its own as a surrogate for risks of bias. Certain methodological limitations of a study, imprecisions, inconsistencies, and indirectness were factors independent from the study designs and can affect the quality of evidence derived from another study design. In this context of reflections of levels of evidence, where do we place the evidence of narrative, experience, on storytelling? Where do we place, for example, the strong evidence of sufferings and its narrative? Is there no place for experiential storytelling, or should it be placed at the lowest level? In this paper, published in a very important journal, authors write, medical practice is poised as treat insoluble tensions between the known and the unknown, or at least the knowable and the unknowable, the universal and the particular, and the body and the self. Instead, this tension beget and amplified one and other. EVM proposed that clinical decisions have be made on the basis of trustworthy evidence. EVM has earned the reputation of dismissing the importance of the singular predicament of the patient and the individual judgment of the doctor. Some authors have addressed the need to resolve the potential conflict between the objective of EVM and the narrative singularity of both patients and clinicians' lived experience. They have considered narrative-based medicine as a possible remedial avenue. Building on their work, but trying to avoid the implicit opposition, must one choose between narrative-based and evidence-based? A group of clinicians and scholars at Columbia University, not only now, has undertaken a program that explicitly integrates these realms and tries to illuminate fundamental unities between them, calling the effort Narrative Evidence-Based Medicine. This project recognizes the narrative features of all data and the evidentiary status of all clinician tests. There are therefore repositories of places that collect experience as form of evidence which must be taken into account. Clinician experience, patient experience. For example, in Spanish, you can consult the following website. We also currently find works where the narrative is evidence that serves to guide public health policy. For example, this paper. From this perspective, the narrative of the patient or the professional of the professional patient encounters is configured as an important type of evidence, but also something that helps as another lens here to organize and interpret the current evidence.